It's been interesting. Of course, we've tried to watch it from early on and from now. Telehealth can typically be a type of project for a team that could take 6 months to a year to implement. Lots of things to consider. Yet these teams are having to do it in hours, 24 hours, 48 hours, voila, they've implemented in their team. It is complicated. Medicare has, I mean, everyone's very appreciative of the changes because it's been very helpful. There's three different types. There's what Medicare is calling the telehealth, actually two or three different types. That is allowing you to provide the typical services, establish patient or new patient visit without the patient being in your office or in the exam room. It's virtually. However, one of the complications is that it has to be audio and video. It cannot be just audio. And someone said, well, that's not fair. I'm like, well, is it? I think it's incredibly fair that they are reimbursing you the same way that the patient was in the office, even though they're not there. You're just going to have to get creative in educating your patients and helping them. Use the family, use neighbors to help get them ready. And as you know, a lot of Medicare patients, they don't even know what a network is. They don't even not even have a cell phone, period, much less a smartphone. Therefore, video is not an option. There are some other codes that can be used for telephones, just audio discussions, things like that, and they're helpful. But the big change is in the long list of codes that they have allowed to happen for many different services. One of the issues that we were very active involved in helping to correct is when they first made the change, the reimbursement was different for telehealth codes. When I'm saying telehealth, meaning office visits codes for established or new, because it's kind of complicated. It has to do, again, with that background history of practice. It has to do with how relative value units are used against codes and how they're calculated for reimbursement. As up until March of this year or late February, the RVU calculation for telehealth says, oh, the place of service is home. Therefore, if it's home, then that equates to a 30 to 50% reduction in cost. Within the last 45 days or so, Medicare says, we fixed it. We're getting rid of that change. So now that people are reimbursed the same way virtually as if they would have been face-to-face. And Don, that has been incredible. Now, from our perspective, we're trying to keep a list of all these positive changes that have happened in the last 45, 60 days that says, by the way, can you keep this one? Can you keep this one? Can you keep this one? This one, okay, we understand why you want it to go away. Just because people have made such great strides. They've adjusted physician schedules. They can see face-to-face. Then the next hour of the day, they'll see virtual visits. They've got prep people to help test the technical capabilities with the patients, testing audio, video. Some are showing up without their iPad being charged. They're not able to look at a camera. I can see, Don, if we can hold on to these things, I can see in the next 6 months to a year where big healthcare facilities, they'll have field personnel to go to people's homes and making sure they're ready for telehealth.